What's going on, everybody? So I am joined here today with Justin. He is a biochemist PhD, and we are here to debate whether or not saturated fat has a causal relationship with heart disease, specifically atherosclerotic coronary artery disease, cardiovascular disease. Now, I gave him a formal debate proposition, which he agreed to. My formalized debate proposition is Proposition 1, serum LDL/ApoB has a causal relationship with ASCVD. Proposition 2, dietary saturated fat raises serum LDL/ApoB. Conclusion, therefore, due to increasing exposure of the vasculature to said causal mechanism in ASCVD, which is LDL/ApoB, dietary saturated fat therefore has a causal relationship with ASCVD. So in very basic, simple terms, anything that raises LDL/ApoB is going to therefore cause heart disease because ApoB or LDL causes heart disease. And in this case, that being saturated fat. So let me share my screen here. Now, my evidence for Proposition 1, serum LDL-ApoB has a causal relationship with ASCVD. This is a paper titled Low-Density Lipoproteins Cause Atherosclerotic Cardiovascular Disease, Evidence from Genetic, Epidemiological, and Clinical Studies, Consensus Statement from the European Atherosclerosis Society Consensus Panel. So basically what they did was they gathered together literally all evidence, all research on LDL and ApoB and its relationship with ASCVD. So separate meta-analyses of over 200 prospective cohort studies, Mendelian randomization studies, and randomized trials including more than 2 million participants with over 20 million person-years of follow-up, over 150,000 cardiovascular events, demonstrate a remarkably consistent dose-dependent log linear association between the absolute magnitude of exposure of the vasculature to LDL-C and the risk of ASCVD, and this effect appears to increase with increasing duration of exposure to LDL-C. Both the naturally randomized genetic studies and the randomized intervention trials consistently demonstrate that any mechanism of lowering plasma LDL particle concentration should reduce the risk of ASCVD events proportional to the absolute reduction in LDL-C and the cumulative duration of exposure to LDL-C. Now, what this basically looks like is this. So, this is a plot of randomized controlled trials, prospective cohorts, and Mendelian randomization studies. Now, the reason you see different slopes in this graph is due to median follow-up time. In randomized trials, median follow-up time is about 5 years. Prospective cohorts, it's 12 years. And in Mendelian randomization, it's 52 years. So not only are you seeing how the absolute magnitude of lowering LDL affects CHD events, but you're also seeing magnitude of exposure, so over the course of many years. So with a 5-year median follow-up time, about a 1 millimole reduction in LDL-C results in a little over a 20% reduction in CHD events. In prospective cohort studies with 12-year median follow-up, you're seeing a little over 30% reduction in CHD events. And in Mendelian randomization with a median of 52 years, you're seeing over a 50% reduction. And if you can achieve even greater lowering, about 2 millimoles, you're seeing about 35-ish% reduction in randomized trials. You're seeing close to 50% in prospective cohorts, and about 75% in Mendelian randomization studies. Now, along with that, what's also interesting is Mendelian randomization studies have shown that regardless of the mechanism of LDL lowering, you see a proportional reduction in coronary heart disease. And this reduction is aligned with the degree of LDL lowering. So regardless of how LDL is lowered, through whatever biochemical mechanism, you see a proportional reduction in CHD events. So, furthermore, when adjusted for standard decrement and LDL-C, each of the genetic variants associated with LDL-C has a remarkably similar effect on the risk of CHD per unit lower LDL-C, including variants in the gene that encode for targets of pharmacological agents used to lower LDL. So HMGCR, targets of statins, NPC1L1, target of ezetimibe, and PCSK9, the target of monoclonal antibodies, alirocumab and evolocumab, with no evidence of heterogeneity of effect. This observation strongly implies that the causal effect of these variants on the risk of CHD is mediated essentially entirely through LDL, because it would be implausible that variants in numerous different genes involving multiple distinct biological pathways by which LDL is lowered would each have directionally concordant and quantitatively similar pleiotropic effects on the risk of ASCVD. So this basically puts the nail in the coffin. Regardless of any method of lowering LDL, you see a proportional reduction in CHD, and it is based on the degree to which each of these mechanisms can lower LDL. There is no other explanation for how this could be the case if LDL wasn't a causal mechanism. Furthermore, if you take a look at cholesterol-lowering trials, not only do you see the proportional reduction in CHD, non-fatal and fatal events, based on the achieved reduction in LDL, the achieved LDL cholesterol score, but you also see that if you can achieve an LDL cholesterol of 1.8 millimoles per liter, which equates to about 70 milligrams per deciliter or lower, you see that atherosclerosis does not progress. You can actually halt the progression of the atheroma in your vasculature. This also coincides with other research. So this paper is normal LDL cholesterol levels are associated with subclinical atherosclerosis in the absence of other risk factors. So basically, they just got a bunch of people who are normal body weight, non-smokers, don't have high blood pressure, don't have diabetes, generally healthy people. They looked at their serum cholesterol score, and they also looked at their atheroma volume at different vascular sites. Now, as you see serum LDL increase, you see increasing atheroma volume, and you see atheromas at multiple vascular sites as LDL increases. The only time that you see people with no atheroma whatsoever is when their LDL is below 60. So again, this just puts the nail in the coffin. There's no arguing that LDL has a causal relationship with heart disease. So that is conclusive evidence of Proposition 1. And as far as Proposition 2, dietary saturated fat raises serum LDL/ApoB. So I don't know why that isn't loading. Okay, there we go. Effect of saturated fat on fatty acids, on serum lipids and lipoproteins, systematic review and regression analysis. So basically, they took clinical trials on saturated fat and its relationship with LDL. They looked at different types of saturated fat, so lauric acid, palmitic acid, and switched it for polyunsaturated fats, monounsaturated fats, and carbohydrate, and measured how each of those nutrients affected serum LDL and ApoB. So if we scroll down here, effective reducing saturated fat intake by replacing saturated fat with other nutrients. So let me see. So replacement of saturated fat with cis-pupa Results from multiple regression analysis are summarized in Table 2. Significant decrease in total cholesterol of 0.64 millimoles per liter. Where's LDL? Total cholesterol. Okay, there we go. 0.05 millimoles per liter for LDL, and where is it? 10.2 milligrams per deciliter in ApoB. That's for each 1% replacement of dietary energy. Replacement of saturated fat with cis-MUFA. So again, this is replacement of saturated fat with 1% energy from cis-MUFA. Significant decrease in total cholesterol, 0.046 millimoles, 0.042 millimoles for LDL, and 0.78 milligrams in ApoB. Replacement of saturated fat with carbohydrates. So that resulted in a 0.04 millimole per liter reduction in total cholesterol, 0.033 millimoles per liter in LDL, and 3.6 milligrams per deciliter in ApoB. And on top of that, there's this paper, Dietary Lipids and Blood Cholesterol Quantitative Meta-Analysis of Metabolic Ward Studies. So they took 395 dietary experiments, which were all metabolic ward studies, highly controlled. Isocaloric replacement of saturated fat by complex carbohydrates for 10% of daily calories resulted in blood cholesterol falling by 0.52 millimoles per liter. Low-density lipoprotein cholesterol falling by 0.365 millimoles per liter. Isocaloric replacement of complex carbohydrate by polyunsaturated fat for 5% of dietary calories resulted in total cholesterol falling by further 0.13 millimoles per liter. Low-density lipoprotein falling by 0.11 millimoles per liter. Similar replacement of carbohydrates by monounsaturated fats produced no significant effect. So there's the concrete evidence for Proposition 2. So since it is irrefutable that serum LDL ApoB has a causal relationship with heart disease, and it's irrefutable that saturated fat does, in fact, raise serum LDL/ApoB. Therefore, due to dietary saturated fat elevating serum ApoB or LDL, it starts that causal chain in increasing risk of ASCVD. Now, the only way you could somehow make an argument against that is if you come up with some weird nonsense excuse that somehow the two propositions don't logically lead to the conclusion, because both propositions are absolutely true. And again, this is further supported by meta-analyses of randomized trials and prospective cohorts on saturated fat and its relationship with heart disease and heart disease events. We can get into some of that later, but that's my opening statement.
Okay, all right, I'll switch over in screen share. All right, so the beginning of this, my stance against this, first of all, I don't disagree with the conclusion or the statement that saturated fat does have some effect on LDL-C and ApoB. The effect isn't really all that incredibly strong, but it's there. I also agree that high LDL-C and ApoB increase risk of cardiovascular disease. I don't disagree with that, but it's also an incredibly weak association. And so if you want to connect something by a causal chain, in basic logic diagramming, the only way that you can actually directly connect a causal chain is if the first proposition always leads to the second. For example, if you have an allele for Huntington's disease, dominant inherited condition, you will have Huntington's disease. If the penetrance is 100%. If you have Huntington's disease, you will develop dementia. The penetrance is 100%. And so they perfectly overlap with each other, and there's no wiggle room there. In this particular debate, there are people that eat a lot of saturated fat that don't experience large increases in LDL-C or ApoB. There are people that have increased LDL-C and ApoB that don't develop heart disease. And so you have actually a relatively small amount of overlap between the two, or three propositions really. And if you throw in another variable like saturated fat, you can't be sure which subset of this Venn diagram you're impacting. And all the data that you showed, you didn't once directly connect saturated fat to heart disease. You connected saturated fat to LDL-C and ApoB. And then separately from that, you connected LDL-C and ApoB to heart disease. And it's shocking that you're trying to play leapfrog from one conclusion to the next when there's an enormous amount of data actually skipping the in between and going directly from saturated fat to heart disease. That's part of the data that I'm going to show. So, thing one, the impact of saturated fat intake on ApoB is relatively small. This is a clinical trial where saturated fat intake was reduced by more than 60%, so about a 2/3 reduction in saturated fat. And they measured ApoB and LDL-C levels and a few other things. Interestingly, they saw an increase in ApoB at a whopping 5 milligrams per deciliter, which is almost trivial. But they saw also a decrease in HDL cholesterol, which is not a good thing, an increase in triglycerides, and an increase in lipoprotein A, which is another increased risk factor for heart disease. So part of my point, it's not a single variable. When you eat saturated fat, which by the way isn't a single molecule, there are dozens of different varieties of saturated fat, it's going to have multiple metabolic biochemical impacts throughout this person. ApoB and LDL-C are one of those impacts. These are other ones that are independent risk factors, and they also matter. Okay, so let's take a closer look. Sample size from a very, very large trial, over 95,000 different people, measured LDL-C and ApoB, and their outcome was cardiovascular disease. Interestingly, what they found is that LDL particles, this has been known for a very long time, are not the only place that you find ApoB. ApoB is found on the surface of LDL. It's a protein that binds LDL receptor, clears it from tissues, but you also have ApoB on VLDLs and IDLs and other cholesterol-containing particles. Okay, so they're taking people and comparing them based on whether their LDL and ApoB content are concordant, whether they match each other, and then also looking for discordant or excess ApoB beyond what LDL would predict, right? And baseline characteristics, these are other things they measured. Do they smoke? How long have they been smoking? What's their BMI? Do they have diabetes? These are all things that are potential confounding variables, right? You can't just go directly from something simple like cholesterol or ApoB and straight to heart disease without realizing that people with high ApoB, they're also heavier. They're fatter, they have higher blood pressure, they're more likely to be smokers. Those things have to be corrected for, and that throws a huge amount of uncertainty and variance into every possible study, right? But looking at the data, they measured three major things, right? So they graphed LDL cholesterol and apolipoprotein B versus risk of myocardial infarction and ASCVD and all-cause mortality. Now, I will grant you there is a pretty straightforward relationship between both LDL and ApoB and risk of MI or ASCVD. That's clearly true. But if you zoom in on all-cause mortality, it's a U-shaped curve. It's not clear-cut. I realize this isn't an explicit part of the debate proposition, but what this is effectively showing is, yes, if you increase cholesterol and ApoB, risk of heart disease does go up. But the highest mortality rate is actually at the lowest level of cholesterol or apolipoprotein B. And this background bell curve is showing normal distribution of the population. And so if what you care about is actually being alive and not necessarily how you are alive or not, then the best place to be is right about here, somewhere in the middle, and if anything, slightly to the right of the median for both cholesterol and ApoB. And so if you're going to say that you want to do an intervention to lower someone's cholesterol or ApoB, if they're sitting at the average, then lowering them actually makes them worse off. If they were over here on the high end, then yes, I agree with you that lowering them would be a good thing. Okay, so that is throwing a bit of a wrench in the data, right? Next, pick apart the data a little bit more. Okay, so what's the best predictor? Excess ApoB above the predicted level of LDL-C is the better predictor of heart disease than just ApoB or LDL all by themselves, right? And so when you look at excess ApoB beyond what's predicted by LDL, then it's not U-shaped anymore, right? Then it really is the more you have, the worse off you are. But interestingly, even with that, all-cause mortality, right? Multivariate adjusted for smoking and BMI and all these other things. In men, at least, p-value insignificant. No meaningful difference. Look at how tightly together these curves are packed. The difference is almost trivial, right? And when you look even closer, you can sort people, right? Segregate them by their LDL cholesterol level, right? So 2 all the way up to 5 millimolar, insane. And so we're saying sort them by cholesterol and then rank them by excess ApoB on top of that. And then this is their hazard ratio, right? If you guys aren't familiar with hazard ratios, 1 basically means no change. Anything above 1 is worse. And so having excess ApoB is clearly a bad thing, but having low cholesterol with excess ApoB actually has a much worse hazard ratio than having very high cholesterol, obscenely high, 5 millimolar, right? Only 1.2. And so the amount of LDL cholesterol you have doesn't really appear to matter. It's the amount of ApoB that you have that is not explained by LDL. And in your proposition, you're claiming accurately that saturated fat leads to an increase in both LDL and ApoB, which would be a concordant increase. If you increase them concordantly, there is no negative effect, right? It's only if you have excess ApoB that is not tied to LDL-C. Okay. As to your Mendelian randomization studies, I pulled the actual hard data instead of just highlighting in an abstract. Mendelian randomization for predicted changes based on genetic variation for ApoB. The hazard ratio or odds ratio for coronary artery disease, not great. I mean, 1.5, 1.6, that's weak, but it's something. All-cause mortality, only 1.15. The smoking hazard ratio for lung cancer is greater than 20, right? 1 is basically the equivalent of 0 because it means no change. This is a painfully small effect. It's so incredibly tiny that they needed sample sizes of like tens of thousands of people to be able to put a statistically significant p-value on it. And so is there an association between genetic risks of ApoB increase and heart disease? Yeah, but the all-cause mortality is lower, which means these people must be dying from something else, right? And that point holds for the mortality curve from the ApoB data too. If we're saying that cardiovascular disease increases mostly linearly across that spectrum, and all-cause mortality is actually higher on the low end, if these people aren't dying from heart disease down here, it means that they are dying from a bunch of other things. And what those other things are is not entirely clear, but it clearly is the case. Okay. All right, next. So the biggest problem I have with your presentation is you didn't link saturated fat directly to heart disease. You did indirect linking of proposition 1 to 2, and then you dealt with 2 to 3. And since one does not always lead to the other, that's just disingenuous. There's better data out there. So systematic review and meta-analysis directly connecting saturated fat intake to heart disease. Saturated fat intake was not associated with all-cause mortality, CVD mortality, ischemic stroke, type 2 diabetes, no convincing association between saturated fat and CHD mortality, right? And if you look at the odds ratios, they basically all line up right along 1. Error bars overlap with 1. P-values are statistically insignificant, right? An example, interesting thing I found in this study, trans fat. Everyone agrees that it sucks. It's horrible. I agree with that. If you look at industrial trans fats that are made through artificial processes, odds ratio above 1, they're clearly causing harm. If you look at naturally occurring trans fats from ruminants, which means cows, so in milk, they actually tend to fall below 1. Metabolic biochemistry is a lot more complicated because these molecules we're talking about are not single classes, right? Next, prospective cohort study, because true randomized controlled trials for saturated fat intake don't exist. They haven't been done. Again, systematic review and meta-analysis. Risk ratios were not statistically significant for CHT deaths and total saturated fat consumption, right? Again, current evidence does not clearly support guidelines that encourage high consumption of polyunsaturated fat with low total saturated fat. When you try to connect the two directly to each other, it just does not happen. Again, meta-analysis of trials comparing different types of fatty acid intake to coronary heart disease. Total saturated fat, exactly on one, meaning no effect. The only thing that showed a beneficial effect was omega-3 fatty acids, which are mostly found in seafood. And the only thing that showed a negative effect was trans fats, which again, no one is in a whole lot of disagreement about with those. All right. They also tested blood markers. Sometimes people are inaccurate or they lie on diet surveys. Saturated markers of saturated fatty acid metabolism in blood markers, and they even sorted it out by different chain length saturated fats, most of them neutral, a couple even beneficial. Omega-3 fatty acids, again, beneficial. Trans fats, again, harmful. No real dispute there. And so study after study, meta-analysis after meta-analysis, even the Cochrane collaboration, which is a group of physicians from all around the world that recur or that evaluate evidence, direct quote from their paper, no effect of reducing saturated fat on non-fatal MI, CHD mortality, stroke, CHD, none of it, right? And lastly, one more meta-analysis of association between saturated fat and cardiovascular disease. Squares are studies, not individuals, but whole studies, because it's meta-analysis, looking at CHD. Diamonds are stroke. Y-axis is statistical power. As statistical power increases, the risk ratio effectively hovers along 1. There was actually a mild benefit detected for saturated fat intake for stroke, and basically no effect at all for saturated fat and heart disease. So I have laid out a very clear case showing that if you go directly from saturated fat to heart disease, your supposed inferred connection completely disappears. And my question for you is, why are you insisting on going from A to B and then separately from B to C when there's very good data trying to go directly from A to C, saturated fat to heart disease, disproving your hypothesis?
Can you turn off your screen share?
You
If you're
should be
done.
able to boot me off. There we go.
There we go. Okay, a lot to unpack there. So you made a few errors. The one study you showed, it showed that there was only a mild increase. It was like African study or an African population.
African American.
Yeah. So they noted there was only a 5 milligram per deciliter increase in either LDL or ApoB. Can't remember which.
ApoB.
Yeah. With only a 5 milligram per deciliter increase, that's literally a difference in 1% difference in saturated fat intake. So if you take a look at the systematic review I sent you, a 1% reduction in saturated fat intake with replacement of carbohydrate would account for about a 5 milligram per deciliter reduction in ApoB. So there was basically no difference in saturated fat intake between the two groups. No shit, you're not going to see a difference between the groups. So this is an issue with most studies on saturated fat reduction and seeing if that would actually result in differences in cardiovascular outcomes. They very rarely ever achieve significant reductions in saturated fat. And again, you can confirm this by just looking at their LDL or ApoB scores. If you detect,
just to jump in, I have the data from that trial, 15 to 6%. At the beginning, 15% of calories were saturated fat. I believe it was 6%.
Well, no.
Throughout the
it couldn't be the case because, again, we have systematic reviews and meta-analyses of metabolic ward experiments and clinical trials. The prediction in reduction or increase in saturated fat is extraordinarily consistent between individuals. You can predict the change with over 90% accuracy. If you only see a 5 milligram per deciliter decrease in their ApoB, that would account for a 1% reduction in caloric intake from saturated fat. So that is literally impossible. They might have reported that they reduced by 15% just because they're clicking off like dietary surveys. But again, we can just confirm that's not true. These aren't metabolic ward experiments where people are literally just being fed particular meals that are like carefully designed. These are people who are just given basically a nutrition lecture saying, okay, next time you eat butter, substitute that out for like a some sort of vegetable margarine or some sort of oil. That doesn't actually mean they're going to stick to the diet. And there may be something to the particular population. These were African Americans. I'm black, by the way, so don't call me fucking racist for this. But black people eat like shit. That's why they have higher rates of heart disease, diabetes, and crap like that in America. They're fat as fuck. They have higher rates of obesity. They eat like shit. And if you do some sort of dietary intervention with these sorts of people, I wouldn't just take their word for it after they get dietary consultations. Oh, sure, they'll reduce their saturated fat intake. Again, just looking at the data, 5 milligram per deciliter decrease in ApoB, that proves they didn't reduce their saturated fat intake. It proves it.
All right, look, I'll grant you that some of those things might be true. I agree with you that if people are self-regulating their intake, it's not entirely reliable. Can you address the point about why don't you care about trying to directly connect
No, I
saturated
do.
fat to heart?
No, I do. We can get into that bit of data later. Let me just. There are a few other points that I wanted to address. Well, on that topic, anyway. The main reason why you see the sort of mixed evidence from these different meta-analyses, there's some well, quite a few actually. The majority of meta-analyses that have been published have shown a benefit in reducing saturated fat. Now, not typically in all-cause mortality, but in terms of non-fatal and fatal myocardial infarction, they do tend to see a benefit. The ones that don't see a benefit, what's going on there is, again, they haven't actually achieved a significant reduction in saturated fat. Not all of these randomized trials actually take a look at these people's serum cholesterol score and the change in their serum cholesterol score over time. They're just taking a look at the event rate. If you don't actually take a look at their serum cholesterol score, you actually have no idea if they're truly reducing saturated fat intake. And that Cochrane review you actually sent me, they did actually do an analysis on studies that looked at cholesterol intake. Now, they excluded, I'll pull it up. Let me take a look.
I guess like in the background of this, I guess my question is like everything that you showed in the introduction, none of it linked or saturated fat to heart disease. So why a meta-analysis of something?
Well, we're doing that now. We're doing that now,
okay.
So don't worry. So there's the Cochrane library. Give me a second. Reduction in saturated fat intake for cardiovascular disease. So, inclusion criteria, randomized, intention to reduce saturated fat intake or intention to alter dietary fats and achieve a reduction in saturated fat compared with higher saturated fat intake on usual diet. Not multifactorial in adult humans with or without cardiovascular disease, but not acutely ill pregnant breastfeeding. Intervention duration at least 24 months. By the way, that's also an issue. Now, what you'll see in a lot of clinical trials where they use like drug interventions like statins, statins don't seem to have a benefit within a year. So when you are looking at these clinical trials on statins, they don't have a benefit within the first year, but by year 2, they seem to have a benefit. This seems to have something to do with the absolute magnitude of exposure of LDL. So it's kind of like if you were to take a drug that is going to reduce heart disease by lowering LDL. If you look at the event rate after a day, well, it's only a day span. There's probably not going to be any difference between each group. If you look at a week, there's probably not going to be a difference between each group. If you look at a year, maybe you'll see a bit of a difference, but again, that's not much time. By year 2, that's a long enough time where you have long enough absolute magnitude of exposure where you are typically going to see changes in event rate. And that only increases with further duration of exposure. So again, this is a problem with a lot of studies on saturated fat. The follow-up time just isn't long enough, but they did seek out studies with a duration of at least 24 months. So main results, we included 15 randomized controlled trials that used a variety of interventions providing all food to advice on reducing saturated fat. The included long-term trials suggest that reducing saturated fat reduced the risk of combined cardiovascular events by 21%. So that's non-fatal and fatal myocardial infarction. Now, meta-regression suggested that greater reductions in saturated fat reflected in greater reductions in serum cholesterol resulted in greater reductions in risk of CVD events. So that's a big fucking deal because, again, proving my point, if you see substantial reductions in serum cholesterol, that perfectly coincides with a reduction in CVD events. And they go on to explain that explained most of the heterogeneity between trials. So basically, trials that saw no reduction in CVD events, that was due to not actually observing a reduction in serum cholesterol. And the reason they wouldn't see a reduction in serum cholesterol is because they didn't actually achieve a significant reduction in saturated fat. Again, the effect of saturated fat on your serum lipids is highly predictable. For each 1% decrease, depends on what nutrient you're replacing it with, but it's going to be somewhere between 5 to 10 milligrams per deciliter in ApoB.
Okay, so just for clarity, can you read the next sentence? Number
Yeah.
needed to treat?
Yeah, so the number needed to treat for an additional benefit outcome was 56 in primary prevention. So 56 people need to reduce their saturated fat intake for 4 years for one person to avoid experiencing a CVD event. Secondary prevention trials, the number to treat was 32, so you saw a greater benefit with secondary prevention. But again, those are sicker people
So,
who are going to be
yeah,
more prone.
NNT of 56. That's like, okay, so 56 people have to change their diet to reduce or to remove one CVD event. And if you scan down one paragraph, like that was where I quoted, like on the next page, the first paragraph, little to no effect of reducing saturated fat on CHD mortality.
Yeah.
Right. And so I'm not saying there's
Yeah.
no effect. What I'm saying is it's not really affecting
Yes.
overall mortality.
Yes, but the issue is due to there again not being that significant of a difference between the two groups, the low saturated fat group and the high saturated fat group. So I'll scroll down and I'll show you. There's an area where they discuss cholesterol specifically. Give me a second.
The outcomes, the majority of the data is in the table fairly close to the beginning of the document, summary of findings.
So here we go. Successful cholesterol reduction. We would expect saturated fat reduction to reflect in total LDL cholesterol reductions, which may be more accurate assessments than self-reported saturated fat intake. So again, most of these trials are not conducted in a metabolic ward. I think there might have only been one where food was actually provided. So when you're just telling people, next time you grab a stick of butter and like throw it in a pan when you cook your steak or something, replace that butter with oil, that doesn't mean people are actually going to do it. So
No, I
9
agree.
RCTs, 10 comparisons provided information on serum total or LDL cholesterol levels in the intervention and control arms during the study, and found a reduction in the intervention arm compared to the control group. Or where variances were not provided, show reduction of at least 0.2 millimoles in the main intervention measure compared with control. Now, 0.2 millimoles is fucking nothing. Give me a second. Millimoles, 0.2. That's 7.7 milligrams per deciliter. So, again, if you're wondering why they didn't actually detect all that substantial a reduction in total like MI risk, both fatal and non-fatal, they only saw a 20% reduction. Well, again, there was only 10 RCTs that actually looked at serum LDL, and the cutoff here for this inclusion was 0.2 millimoles. So basically, they started with practically zero reduction in LDL. Maybe some got a little higher, but if that's the cutoff, no shit.
That's the minimum. That's not average.
No, that's not average. That's the minimum cutoff.
Yeah, so
Again,
that
that's a
anything
tiny
that
minimum cutoff.
I know, but
In
that's the
most,
lowest possible change.
so
They're like obviously the majority of the data were greater than that.
yes, I understand, but when you're looking at most statin trials, they're able to achieve about a 1 millimole reduction. So if they're doing this sort of cutoff, I don't like. I would love to see, what they found. I don't even know if they even had a single trial that achieved a 1 millimole reduction. So that's the main reason why you don't actually see all that significant of a difference. It's basically just because they don't see they're not sticking to the diet. They're told to reduce their saturated fat intake, but they don't really. Maybe they do a little bit, but again, they're only achieving reductions of a bit over zero point 0.2 millimoles. I don't think there was even a single trial included that achieved a 1 millimole reduction, which would have been roughly 38 milligrams per deciliter, which would
Right,
be pretty
but my
substantial.
point is that you can't, it is very, very difficult. I think it's possible, but very hard to achieve that much of a decrease just by diet alone. It would have to be a pretty extreme
No,
change.
very no. That so when we're comparing people who, if you were looking at me, I eat a very low saturated fat diet. So as a percentage of daily calories, it's probably about 2%, if that. Practically no saturated fat. I also eat a very high fiber diet. I also exercise like fucking crazy. I get about 2.5 hours of exercise per day. That's a combination of weight training and cardiovascular exercise. And I have a low body fat percentage. It's around 10%. If you were to ask me to get a millimole reduction in my LDL or ApoB, that would be practically impossible for just with lifestyle intervention alone. Let alone diet alone, but just lifestyle intervention alone, because I'm practically doing literally everything to get my cholesterol as low as possible. Now, if you were looking at somebody who didn't have my lifestyle, so let's say they were your average American, overweight, maybe around 20% body fat or more, did consume a substantial amount of saturated fat, over 10% of daily calories, a reduction in saturated fat intake from 10% of daily calories to, say, 2%, no, that would be substantial. Again, based on the systematic review I sent you, there's about a 10 millimole per 10 milligram per deciliter decrease in ApoB when you replace saturated fat with polyunsaturated fat. So with an 8% reduction, 8 times 10, that would be 80 milligrams per deciliter in ApoB. That's substantial.
It is, but just pause for a second. The average ApoB in the population is somewhere between like 90 and 100. And so if people are consuming 15% of their diet by saturated fat, if you're saying 10 milligrams per deciliter per percent, if the average is 90 to 100 and you knocked off
It's above
10%
that.
off the saturated fat intake, what's that?
No, it's definitely above that.
I have the
I'm
distribution.
pretty sure it's between 120 and 150.
Even if it's 120, I'll give you 120. Okay, so someone goes from 15% saturated fat down to 3. That's a 12% reduction. That should take them from 120 to 0. That's not even close. There's no way that happens. No one goes to 0. There's
you
something
can get
wrong
to
with
single
that.
digits.
But are you recognizing that there are other reasons why LDL and ApoB go up? Eating a shitload of sugar will make your LDL and ApoB go up because it triggers de novo metagenesis in the liver.
Well, that's only with increased caloric intake, not with isocaloric exchange.
Okay. So just like let's just I'm not trying to be overly contentious. Just
Yeah,
I kind of
sure.
want to get to the because I think I agree with you on more
Well,
than
by
you
the way,
realize.
before you finish that point, this was also data from the Cochrane review, exploring saturated fat cutoffs. So all-cause mortality, CVD events, myocardial infarction, non-fatal MI, stroke, CHD mortality, CHD events. So when you look at percent energy from saturated fat, below 10% is where you see CVD events and CVD mortality hit rock bottom. Once you get up to 9%, that's when you see a sharp increase. And again,
Okay,
this is
mine barely, but
sorry.
all cause mortality is like if you look at again
You
like right
wouldn't
here
expect it to increase. So yeah,
if
that all
CHD
cause mortality is
mortality,
all cause mortality.
what's that?
All cause mortality is all cause mortality. Like people are going to die of something. So
I understand that,
there,
but my point
I
is
wouldn't expect
if
saturated fat to increase risk of death from all causes. I'd expect it, for the most part, to increase risk of CVD events, myocardial infarction, non-fatal MI.
But my point is, if you reduce risk of CVD mortality, which is a major cause of mortality, it's the most common cause of mortality in the United States. So if you decrease CVD mortality, but all cause mortality barely budges, those people must be dying from something else instead of CVD.
Yeah,
Or the
so
math doesn't.
that we can actually cover that topic because you did mention what's it called? Increases in mortality with lower cholesterol, and you mentioned like a sweet spot.
Yeah. So I'm genuinely
Yeah,
curious. What do you think of the U-shaped curve?
yeah. So that's reverse causation. So you don't see that in clinical trials. You don't see that in randomized trials. You only see this in prospective cohorts. And this is due to disease triggering these deaths. And as a direct or indirect effect of disease, you see a lowering of cholesterol. Especially after cardiovascular events, you actually see a sharp decrease in LDL cholesterol. And as heart disease progresses, you actually typically see a reduction in cholesterol. So over time, as atheromas develop, you actually typically see people's cholesterol go down. And as they get sicker and sicker, their cholesterol levels go down. And again, after a myocardial infarction, you typically see a massive reduction in cholesterol immediately
Right.
after
But
the event.
this data was not from people with heart disease. This is a general
Yeah, I
population
know.
study.
Yeah, I know. And that explains the data. So again, if you look at Mendelian randomization studies, they do not actually detect this. In fact, they show the exact opposite. People with alleles that lower their LDL cholesterol, they live longer, and you see a higher frequency of those alleles in elderly populations. Whereas people
I'm
with
not
alleles
disagreeing
that
with
raise LDL, they die younger, and you actually see a lower proportion of those alleles in elderly populations.
I'm not completely disagreeing. I think the effect is minor, but I'm not disagreeing with you on that. My point is there are lots of different ways to change LDL and ApoB. So
I'm
let me
not, yeah, so I understand that. Exercise will lower LDL ApoB, weight loss will lower LDL ApoB, reducing stress will lower LDL ApoB, getting enough sleep can lower LDL ApoB. And on top of that, there's multiple risk. Wait, diabetes. If you have untreated diabetes, that will particularly elevate ApoB. And you actually mentioned there's a greater association with elevated ApoB that's when it's disproportionate to LDL. That's an indication of diabetes or metabolic syndrome. So people with metabolic syndrome or diabetes, they tend to have a disproportionate amount of total particle count. Um, that's fairly rare. 90% of the time, LDL is not discordant with ApoB, and it's an easier, more common test to just get the molecule count rather than the total particle count.
yeah,
So
I think
for the majority of the majority of populations, LDL is a very accurate approximator of ApoB. I agree, ApoB is more accurate and it more accurately assesses risk across all populations. That's why in the propositions I mentioned LDL and ApoB. So I don't disagree with that, but your reasoning here has just been disproved. Low LDL is not a risk factor for all-cause mortality. This association is just reverse causation. Again, this is being absolutely refuted with Mendelian randomization studies. There's also prospective
what
cohorts that account
I want
for reverse causation.
I hit this point. I'm not saying that if you just pressed like a magical delete button on LDL, that it would lead to increased mortality. That's not my point. My point is that behaviors and environmental things that people do, like diet, that lower LDL cholesterol, those things potentially could have causation. But like, I don't want to, I know we have, I don't know how much time we have, but I think the thing that I want to try to convey is we're not nearly as far apart as you think we are. And the main
Well,
reason
you
for
literally agreed to both propositions and my conclusion. So by that
um,
definition,
no,
you
no,
conceded.
just to clarify, I did not agree to both your propositions.
You
I
did.
agree to the proposition that increased ApoB and LDL-C in a subset of individuals cause
It's
ASCVD. I
not a
agree with you.
subset of individuals. It's all individuals.
Dude, it's not a subset. If it's not a subset, then why aren't everyone on this far end of the distribution having heart attacks? They're not. And there are people on the very low end
Yeah,
that are having.
yeah. So again, assessing a whether or not a mechanism is causal is about statistics. Not everybody who smokes is going to get lung cancer. Not everyone who smokes is
It's
going to get
not
a heart
about
attack. I had a neighbor who lived down the street from me. He smoked since he was 14 years old. He lived
if
to
you
98 and he died in his
if you
sleep.
use statistics from non-experimental studies that are looking at
No,
associations.
no, that's not true. I literally just showed you the paper from the European Atherosclerosis Society. They collected
That
data from clinical randomized trials, prospective cohorts, and Mendelian randomization studies.
paper did not
Mendelian
address that.
randomization studies are naturally randomized, and they also had randomized trials from lipid-lowering therapies.
That paper did not address saturated fat. It didn't. It
We're not
addressed
talking
LDL.
about saturated fat right now. We're talking
That is
about
the
whether or
entire
not
premise.
cholesterol is causal, so you're just changing the subject.
That is the entire premise of this debate is does saturated fat cause heart disease? You don't need
Yes.
to link it to LDL-C and
So you
ApoB.
just said you disagreed with P1 of my argument. So what's the disagreement of P1?
The disagreement is that the causation is not direct. I agree that it increases risk by some percentage, but that some percentage is relatively small. I am showing you
So,
risks that are
so
tiny.
again, if you look at the data that I showed you from the European Atherosclerosis Society on cholesterol, they saw about a 30% risk reduction after 5 years when cholesterol was lowered by 1 millimole. That's
Dude,
from randomized trials. In prospective
the
cohorts,
debate
it was even larger,
proposition
and in
is
in
not that
Mendelian
reducing
randomization studies, it was
LDL-C.
even larger.
That is not the proposition that we're arguing. We are not arguing about whether
Yet, so I
LDL-C is
just asked
associated with
you,
heart
what is your disagreement with P1? You said your disagreement with P1. We're talking about P1 right now. Serum LDL ApoB has a causal relationship with ASCVD. So, what is your disagreement?
My disagreement is that you have a fundamental misunderstanding of what the phrase causal relationship means. You
So,
have
so again, disagreement with P1. What is it?
that you're using the term causal relationship to imply that if A has an association with B, right? That saturated fat in the diet has some sort of association, which is nowhere even approaching complete, right? It's not even anywhere even in the ballpark of A always leads to B. We have an A
What do
sometimes,
you
and
mean always leads to B?
I mean, if you have an allele that causes Huntington's disease or muscular dystrophy or cystic fibrosis, you will always have that disease. It's 100% of the time, 100% penetrance.
Okay,
If
so
you
smoking doesn't cause lung cancer because not everyone who smokes gets lung cancer.
No, I'm not saying it's impossible for it to be causal. What I'm saying is that you have incredibly weak evidence
No,
because
it's not incredibly weak. What makes it weak?
all right, the risk ratio for smoking, let me find that slide. The risk ratio for smoking is over 20. If you smoke, you are 20 times more likely to get lung cancer than someone who doesn't.
Yeah, that's
That is very
because
strong evidence.
that's because the absolute risk is low. An HR of 20 for smoking increases your absolute risk of lung cancer from less than 1% to about 1%. Now, the prevalence of heart disease is extremely common. Because it is so common, you're going to expect lower HRs. HRs for heart disease cannot come anywhere close to HRs for smoking just because the absolute prevalence of the
I
disease.
understand because there's no clearly defined mechanism. You don't have a biochemical
No,
mechanism
no,
making
there.
ApoB.
So, first of all, you don't need a biochemical mechanism to establish causation.
I'm
So
going to go
that's
ahead and
just
disagree.
nonsense. Sorry?
That is not enough. If you don't have a mechanism, you're making assumptions. Even in the paper that
No,
you sent me, the very first one that you really liked, they said this implies. It's not direct evidence. It is indirect evidence that requires implicit assumptions. You're making a series of assumptions to get to your conclusion.
right. So, again, can you take off your screen share, please?
Sure. And also, just to be
Oh,
clear,
wait.
I'm not saying it's impossible that there
There
is
we
some
go.
sort of. I just think it's incredibly weak.
So, first of all, this isn't incredibly weak. I've gone over this already. Not only what was it stated in the paper. So again, this was separate meta-analyses of over 200 prospective cohort studies, Mendelian randomization studies, and randomized trials,
That
including
is
more
not
than 2
involved.
million participants with 20 million person-years follow-up, over 150,000 cardiovascular events. There
And
was a
those did
dose-dependent
not involve.
log linear association between the absolute magnitude of exposure to the vasculature to LDL
Dude,
and the
I'm.
risk of ASCVD. That is
This. No,
extraordinarily strong evidence.
look at the
And not
axes
only
here.
that, I would love to hear your explanation for how the hell, regardless of the method, that LDL is lowered. So that could be through different biochemical mechanisms like HMGCR, NP1L1, and PCSK9. All of
It's
these mechanisms of cholesterol lowering reduce the risk of CHD. And
All right.
each of these mechanisms reduce the risk of CHD proportional to the extent they reduce LDL. If that
Can
isn't
I
causal, I would love to hear your explanation for that.
Okay, let me throw out an example. I worked at the Research Institute at the Cleveland Clinic at one point. They ran a clinical trial using monoclonal antibodies to dramatically reduce LDL particles in the blood. That trial was ended less than 2 years in because they detected increased mortality in the treatment group. You can look it up,
Okay.
right? I completely disagree with their conclusion that reducing LDL-C always
Yeah,
improves
wasn't
outcome.
that so? Wasn't that with the first generation of those monoclonal antibodies? The newer ones don't increase mortality.
But they also don't really decrease it very much either. All-cause mortality, barely
Well,
a drop in the.
again, currently, PCSK9 inhibitors don't lower LDL to the same extent that statins do.
Okay,
Usually,
this
they're
is
used as an adjunct treatment.
a very recent statin trial. Those are risk curves. Red is control, blue is statin. There is a minor reduction in the statin treatment group throughout the trial, and then by year 7.5 or 8, they fucking cross each other. This is
Okay.
the benefit that we're so incredibly happy about.
What was the magnitude and reduction of cholesterol? And again, I wouldn't necessarily expect statins to necessarily reduce all-cause mortality. So, by the
Dude,
way, this is hypertensive
all-cause
patients.
mortality. Why are you taking the drug?
By the way, this is hypertensive patients without other cardiovascular disease in primary care, hypertensive patients without other
Look up
cardiovascular
look up
disease or
any statin
diabetes.
trial you want. They
Sorry?
reduce CVD risk. They barely budge all-cause mortality. It's and like I'm
You're
not a
just
like
okay. Sorry. Cherry picking this one study refutes the meta-analysis of over 200 randomized trials, prospective cohorts, and Mendelian randomization studies.
if you're going to call this cherry picking, the data that you're showing me don't actually even directly relate to saturated fat. You're picking a
We're
completely
not
different.
talking about saturated fat. We're talking about
That is, do you
P1.
read the title of
We're
like how
talking about P1. You
you are
said you
so
disagreed with P1.
dude,
So
fuck
why are you
P1.
bringing up saturated fat when we're currently arguing about P1?
Because you don't need your separate propositions to links. Just make one proposition altogether. Saturated fat causes heart disease. You don't need LDL-C and ApoB to link the two. You're inventing that need
So
because it's the
no,
only.
no, no. That is fundamental to my argument because the mechanism in which I'm proposing that saturated fat raises risk of heart disease is due
That's
to
not
the
a mechanism.
mechanism of increasing LDL. If
That's not a
saturated
mechanism.
fat interventions don't manage to lower LDL, that would explain why you see a lack of benefit, or if they don't manage to lower it very far. And
LDL
again,
levels are observation. Do you know what a mechanism is?
sorry?
Do you understand what a mechanism is? LDL is not a mechanism. It's an observation. You're measuring something. A mechanism is a biochemical interaction.
Oh, okay. Do you
You,
okay? So, do you think if the studies on cigarette smoking were conducted, say, in the early 1800s, before some of the science was established, we only had prospective cohorts. We just looked at
right.
people, followed their smoking habits, and looked at their event rates, how many people
Mhm.
died or got cancer or something. Are you telling me it
Right.
would be impossible to establish whether or not there was a causal relationship between smoking and like lung cancer or heart disease or death?
I, I think that evidence would be much more convincing because the risk ratio is so enormous. So when you have those association studies, the
So
higher the risk ratio, the higher my confidence
yeah,
becomes.
so I agree, but again, the issue here is that because the prevalence of lung cancer is so incredibly small, you can have HRs that are absolutely massive.
I,
You
I
could
agree.
have an issue where everyone works in like I don't know, a coal power plant and gets like exposed to coal smoke, or works in like a kitchen and gets exposed to tons of like fumes from like high heat pans. they might end up having extremely high rates of lung cancer, and you might end up not seeing a very strong correlation between cigarette smoking and lung cancer risk, just because in those populations, lung cancer is just
I
much
agree with
higher. But
I agree with that. The thing that I'm saying is I know that like getting really, really good data, like the ideal data for this question would be to lower people's saturated fat intake by 10 percentage points for 10, 15 years and see what happens. I realize that we can't do that. That would be the best possible evidence. My problem is it seems like in a lot of nutritional research, people say, well, we can't do that study because it's not reasonable, it's not affordable, it's not feasible. And therefore, we're going to go ahead and pretend like our shittier evidence is just as good. It's not. And I'm not saying that I have great evidence that saturated fat is the healthiest thing in the world. I'm just saying the evidence is weak, and the best evidence are these meta analyses of directly linking saturated fat to heart disease, and
so
they don't show it.
yeah, so again, most meta-analyses do indicate a benefit to reducing saturated fat intake. The
LDL-C and ApoB. That is indirect evidence.
No,
You're
I'm
not
I'm
going.
talking no. I'm talking about I'm talking about meta-analyses of saturated fat intake and its relationship to fatal or non-fatal myocardial infarction
You
or
didn't show me any
CVD
of it.
mortality. What?
Then I have this right in front of you, right? No effect
Okay,
on CVD.
right. That's only one meta-analysis. Before we set up this debate, I think I linked to you like 10.
But all of your meta-analyses they weren't directly linking saturated fat to
No,
heart
they
disease.
were. No, they were. If so, you didn't bother to read anything I sent you. So
So
you didn't bother to read anything I sent you. I sent you about a list of 10 meta-analyses on saturated fat specifically. So you didn't bother to read anything. You didn't open one link.
they were saturated fat connected to LDL, not directly to heart
No, so
disease.
you didn't open one link. You
Then
literally did
open
not
it.
open one link. Okay,
Show
so
me.
turn
Pull it
off your
up.
screen share.
Pull it up. Also, just like, can we back this off a little bit? I'm not. I don't think that what you're saying is just like insane or crazy. I just think the evidence is incredibly weak, and I think that you're giving
So
people recommendations
right,
about things.
so these are all the meta-analyses I linked to you. Effective reducing saturated fat intake on cardiovascular disease in adults, an umbrella review. This umbrella review found the reduction of saturated fat intake probably reduces cardiovascular events and other health outcomes. However, it has little or no effect on
Little or
cardiovascular
no effect
mortality and
on
mortality
mortality.
from other causes. So
Most
they,
people care about that.
sorry?
Little or no effect. You just proved my
So
point.
would you rather have a heart attack or not have a heart attack?
I know that of all the ways to die, a heart attack is pretty much number one on my list, way above cancer or any
Well,
other.
no. Well, no. Would you rather have a heart attack or not have a heart attack?
That's not the question. That's not a fair question.
No. You're claiming, oh, well, they only reduced non-fatal myocardial event rates. So would you rather have a heart attack or not have a heart attack?
Dude, all right. So from a personal standpoint, I know that my blood work numbers are fucking
All else
fantastic.
held equal, would you rather have a heart attack or not have a heart attack?
I'm refusing to answer your non sequitur question. That's not the
It's
question at
not a
hand.
non sequitur. You just said, oh, well, it only reduced myocardial infarction rates. Okay, would you rather have a heart attack or not have a heart attack?
My point is, if it's not affecting mortality for cardiovascular reasons,
So
it must be
you don't care if you have a heart attack? So if I told you if you reduce your saturated fat intake by 10% over the next 5 years, your chance of getting a heart attack might reduce by like 10% or something. You don't
if
care?
if I had to accept an increased risk of heart attack, but I got to trade it for a decreased risk of something like stroke or cancer, I would absolutely take the heart
Okay,
attack.
well, they didn't find a decreased risk of stroke or cancer. So, again,
And
all else
you're
held
you're you're
equal, would you rather have a heart attack or not have a heart attack?
you're failing to understand simple math. If you don't have a change in all-cause mortality, but you do have a change in cardiovascular risk, they have to be dying from something else. Otherwise, why was there no change in all cause? The deaths had to come from somewhere. Where is the somewhere? They won't tell us because they're not measuring it.
So are you telling me saturated fat will protect you from cancer or death from some other cause?
I'm not saying I know what the cause is, but if all cause mortality is flat and cardiovascular mortality goes down.
You
That gap has to be compensated by something.
Yeah, so you understand that just because you have a reduction in, so they found a reduction in myocardial event rate, not a reduction in myocardial event deaths. So basically, that would account for the non-difference in all-cause mortality. The people who ate less
Yes, but
saturated fat just had less heart attacks. So
I
would you
have
rather
data
have more
showing,
heart attacks or less heart attacks? Just
again, non
curious.
sequitur question.
What do you
I
mean
showed
non sequitur question? Do you know what a non sequitur is?
you're asking me a question that has no relationship to the thing that we're arguing about.
Would you rather have more heart attacks or less heart attacks?
All things equal, I would obviously rather have less heart attacks, but all things are not equal.
Okay.
But
So
all
if
things
you'd
are
rather
not.
have less heart attacks, then I guess there was a benefit to reducing saturated fat
Okay,
intake.
so if I said I could give you a pill that would reduce your risk of heart attack by 10%, but would guarantee that you would go blind, would you take it?
Well, that's
Of course not.
that's disanalogous. You're not going to go blind from eating no like little saturated fat.
But I showed you data with a U-shaped curve with all cause mortality.
Okay, well, what if like by eating more saturated fat, your dick is going to fall off? Are you going to still eat steak and butter? Like, what does that have
I,
to do with anything?
what it has to
So
do with is
again, consistently
vascular.
across most meta-analyses, they find a reduction in overall event rate.
All right, dude, have you ever considered the possibility? And this is like I'm being very sincere here. I recognize that there are some things that I really, really like that are not good for me. I love ice cream. I would live off the shit, but I know it's horrible for me, so I barely ever eat it. Right? I admit that I like eating meat. I really like a good steak. I do. And if someone told me that it was horrifically bad for me, I probably would stop eating it almost always. Have you considered the possibility that you're so dedicated to the vegan storyline that it doesn't seem like you're open-minded to the idea
Yeah,
that
so none of this has anything to do with the disagreement on P1, P2, or the conclusion. So I don't really care about any of this.
okay,
Again, most meta-analyses on dietary saturated fat do seem to confer a benefit in at least overall event rate. So just going through
and
these
not
real quick.
on
So again,
mortality.
I sent you 10 meta-analyses that you didn't bother to read clearly,
And you just
and then you
highlighted one of
just
them showing that
lied.
it doesn't affect mortality.
I didn't
Right?
say it reduced mortality. I said it reduced event rate, which was shown by the paper. So again, you just told me that you'd rather have less heart attacks than more. And we can go
Yeah,
into
all things
why some
equal.
of these. So we already talked about this a little bit, but we can go into why some of these didn't see, fantastic results like you see in a lot of statin trials or Mendelian randomization studies.
So
So dietary
just
sat.
curious, one more genuine question. Can I show you one more thing that's new that we haven't talked about yet that I agree is relatively evidence, but I find it a real curiosity. I'm genuinely curious about your take. You
What?
don't have to. So I mean, I have actual data, and I agree that it's not incredibly quantitative. There are natural experiments where groups of people from throughout the world that lived in relatively primitive conditions where they mostly grew their own food, whole food sources, didn't have grocery stores, then moved to more urban areas and adopted a more Western sort of diet, and pretty much across the board, their health got shittier. It didn't really matter starting off if they ate mostly plants or if they ate mostly animals. When they moved to a city and started eating processed food, everyone got unhealthier. So is it possible that like this minutia over how much saturated fat, how much this is the real problem that Americans and probably Canadians too just eat fucking garbage, and that the better thing would be to eat unprocessed whole food sources regardless of their exact macro content?
Depends to what degree you're talking about. Like these issues are multifactorial. The issue with like an Americanized diet is it promotes obesity, which across the board increases your risk of heart disease, diabetes, cancer, like the number one killers.
Totally agree.
Now,
But
if if you can maintain a healthy body weight, but you're eating ridiculous amounts of saturated fat, it could very well be the case that in those circumstances, they're going to be worse off than somebody who's just overweight but eating overall healthier, like less saturated fat, and they can keep their cholesterol lower. There's also going to be some genetic risk factors, like if you have a genetic risk for type 2 diabetes,
Yeah. So
being overweight might be a bigger issue for you than the macronutrient composition of your diet.
I know it's just anecdotal, but this is so I was very, very curious about these things. In my mid to late 20s, I worked in a lab where I had access to all sorts of analytical equipment, and I did a handful of self-experiments. And I wanted to know. So I did like an almost vegan diet for a while. I then switched and ate tons of like eggs and steak and whatever. And I also exercised a lot, to be fair. My blood work barely budged. Total cholesterol never went over 200. Triglycerides were always under
That's
50 or
very
60.
high.
Really isn't.
No, it is. Targets for total cholesterol are now below 150 and
Dude,
LDL
pretty
below
much
100.
everyone admits that total cholesterol is a really, really poor indicator of heart disease risk.
So
That's not even
I know. So what was your LDL?
um like 90 something.
Yeah, so that would still be considered above ideal.
Right, but my triglycerides were incredibly low and my HDL was high, and that ratio
So
was a much better.
LDL is a better predictor than triglycerides.
Triglyceride to HDL ratio is a superior
No,
predictor to LDL.
no, they're not.
Dude, just you can say it all you want, but it's
Well,
not true.
it's not. They do not. So again, LDL, ApoB is the gold standard. LDL is the next best. And like there's trials on triglyceride lowering without targeting LDL, and they seem to have no benefit. So
So dude,
it's not.
we don't have to hash it out now. Just sometimes search triglyceride to HDL ratio.
Oh,
It's a better.
I have, and it's not particularly useful. It's probably a proxy indicator. There doesn't seem to
Then
be a good direct
why do
effect.
most major organizations now admit, even like the American Heart Association, like American College of Cardiologists, they all admit that total cholesterol and total LDL really isn't a great predictor.
No, they
It's
don't.
I
That's
can
not true. They
right,
don't.
well,
They
for
all
anyone
recommend
listening,
lowering
up
LDL as much as possible.
their statement.
So that's not true.
This is no different than how people used to think that dietary cholesterol mattered, and now every organization around the world pretty much admits that no, it doesn't matter.
No, that's not true. Again,
100%
USDA
true.
dietary guidelines, they recommend lowering dietary cholesterol as much as possible while still
But
maintaining
this
adequate
changed
nutrition
less
intake.
than 10 years ago.
No, that's the updated dietary guidelines. You can look it up. They recommend keeping cholesterol as low as possible.
Dude,
So that's not
if you
true.
think dietary cholesterol is dramatically impacting blood cholesterol, you
It
have a
is.
fundamental
Yeah, it
in
is. So
basic biochemistry.
it is. It will raise your LDL cholesterol by about 10 to 15%.
Okay, well, dude, if you want to just say things and not back them up with anything, if for the people that are listening, if you want to actually read science and listen to someone who has experience with metabolic biochemistry or a YouTuber that says shit without backing it up.
Okay, you want me to back it up? Effects of dietary cholesterol and serum cholesterol, meta-analysis and review. Attempts to
Dude,
estimate the effect of dietary
1992.
cholesterol on serum cholesterol by meta-analysis have not previously included baseline together with added dietary cholesterol in a mathematical model.
1992.
So I don't know why it matters when this paper was published.
Because
There's
we have
actually been
dramatically better
okay,
data
great,
now.
okay, sure. Updated meta-analysis. Dietary cholesterol. Let me see. No, that's not it. That's not it.
You're not reading those because they don't show what you want it to show.
No, that's not it. It's not about eggs.
So why do like if you just measure
I
people
think
eating
this is it.
food
Elevated low density lipoprotein cholesterol, a major risk factor for cardiovascular disease. Dietary recommendations. 55 studies were included in the analysis. The nonlinear Michaels, Menton, and Hill models best describe the data across full spectrum of dietary cholesterol changes, 0 to 1,500 milligrams per deciliter. Mean predicted change in LDL cholesterol for an increase of 100 milligram dietary cholesterol were 1.9, 4.46, and 4.5 milligrams per deciliter for the linear,
Do you
nonlinear
realize how
MM and
small
Hill
those
models,
numbers are?
respectively. Sorry?
Those are incredibly tiny numbers.
Well,
That's not
no. Well, no. That's per 100 milligram cholesterol dietary increase.
100
So
milligrams is
one
not
so
insignificant.
one egg is going to contain somewhere around 300 to 400 milligrams cholesterol. So that means if you consume, let's say, the equivalent of 2 eggs per day, which is going to be like, let's just rough number, 600. That means, let's see, 6 times. Yeah, 6 times about 4.5. That's a 27 milligram per deciliter increase. So if you're starting at a baseline serum cholesterol score of about 100, that's a 27% increase. So that's
Okay.
not non-significant. So that's per 100 milligrams. So are you going to admit you're wrong? Dietary
Can I have
cholesterol
my
does
turn
have
to
a
show you something?
substantive impact on serum cholesterol?
I have, can I have my turn to show you something?
Yeah, sure.
All right, let me screen share.
Yeah. Oh, wait. Whoops.
Okay. Advisory statement from the American Heart Association. Evidence from observational studies conducted generally does not indicate a significant
Yeah,
association.
observational studies.
So I just said that the
So
policy statement for the American
you
Heart
didn't listen to
Association.
anything I just said, did you?
Hold on, just shut the fuck up for a second and listen to me, man. I just said that the American Heart Association changed their policy and says the evidence
Yeah,
isn't strong enough
so
to
you're
recommend it. I'm
talking about a
telling you,
completely separate topic. You claimed dietary cholesterol does not have a substantive impact on serum cholesterol. Are you going
I
to admit you're wrong?
no, I stand by that. The numbers that you showed me were pathetically small, and you
So
said that I was wrong.
sorry, going from a baseline cholesterol intake of 0 to an increase of say 5 to 600, which would be roughly equivalent to 2 eggs per day, that would incur about a 27% increase. You're telling me a 27% increase, more than one quarter to your cholesterol score, is insignificant?
No, because that is for a single 100 milligram increase. The effect is not linear because cholesterol triggers a negative feedback response in the liver. So the more you eat, the less is absorbed. It doesn't keep working like that. It's maintained by a
Yes,
negative feedback.
there is compensatory mechanisms, but again, if you let me share the whatchamacall, the N. Hopkins meta-analysis, they found a hyperbolic curve. Let me see.
So why doesn't the American Heart Association recommend limiting dietary cholesterol? I just showed you that that's the case.
Yeah, so that was based
Every
on prospective cohort studies. The fundamental issue with prospective cohort studies is they don't take into account baseline cholesterol intake. That's explicitly mentioned in this
so you're
meta-analysis.
so you're
So
saying
what
that
they
the
did, they looked at clinical trials and they created a model for baseline versus added dietary cholesterol. So when you look at when you account for baseline cholesterol intake, what happens is if you go from 0 to 500, that's where you see the most significant change. 500 to 1,000, you see less of a change. 1,000 to 1,500, and it basically tapers off. What they basically found was that for average individuals, going from a baseline intake of, let me see where it was mentioned. Well, anyway, you can read this paper on your spare time, but basically what they found was going from a baseline intake of 0, adding 500 milligrams of cholesterol to the daily diet, you would expect to see an increase of about 10 to 15% to your LDL cholesterol score. There are
15.
some hyper responders that might see a 20 to 25% increase, but most people would see a 10 to 15% increase, which isn't unsubstantial. That does incur an increased risk of heart disease. Now, dietary cholesterol, I will admit, it's not going to have as substantial of an effect on your serum cholesterol score as saturated fat or fiber or body fat, like just the degree to which you have adiposity. Exercise might also modulate your serum cholesterol to a greater extent, but it's not an unsubstantial change. You would expect over the course of, say 5 years, that would create meaningful changes in risk. And again, like I showed you the paper from the European Atherosclerosis Society.
Get it. It's not, I don't count that as direct evidence. It wasn't addressing the triglyceride or
Yeah,
the
so
saturated.
so the issue is the recommendation you showed me, that's based on prospective cohorts. Prospective cohorts don't take into account baseline cholesterol intake. So if the baseline population is already consuming roughly the equivalent of 1 to 2 eggs per day, and they're consuming people who are already consuming high amounts of cholesterol to people who are consuming even higher amounts of cholesterol, you're obviously not going to see any difference. You have to
So
compare
why is it,
populations that are consuming practically no cholesterol or zero to people who are consuming normal or high levels to actually see a difference.
so why is it that if you do dietary interventions where you have people eat things like eggs, again, admittedly, they're probably replacing something very, very shitty with eggs, that their health outcomes tend to be better?
What are you talking about?
If you do dietary interventions where you add things that have saturated fat, like eggs, for example, to their diet,
Eggs
as an
don't have that much saturated fat. It's pretty low.
they have quite a bit of cholesterol, but either way,
Well,
I actually don't have a whole ton
saturated fat
because
and
I have
cholesterol are not the same thing. Eggs are pretty
I'm
low in saturated fat.
fully aware of that. We were talking about cholesterol. Anyway, I have a hard stop in about 4 minutes. Is there anything you want to do to sort of wrap this up? Clearly, I mean, I knew that we weren't going to agree at the end of the day. I guess I'll leave it like my ending statement is I think that you're relying on indirect evidence. I think that when you try to directly connect the things that we care about, saturated fat and cardiovascular disease, there is very, very weak evidence for an association, and it completely disappears when you look at all-cause mortality, which is what people actually care about. So if we want to have a follow-up at some point, um, I'm up for it. But I don't think that I don't think we're as far apart as you realize we are. I think we're just like really getting into minutia at this point. But
Yeah, so you weren't able to disprove P1. You basically just used like gaslighting tactics, just nonsense, talking about how, oh, well, you can't show some sort of mechanism. Clearly, there is a causal relationship. That's undeniable. That's
you
based
can't
on
just say the
meta-analyses
word.
of
So
randomized trials, Mendelian randomization studies, prospective cohorts, and regardless of the method of cholesterol lowering, either through statins, lifestyle changes, dietary changes, and through different genetic mechanisms that lower cholesterol through the same pathways that some of these drugs target, they all reduce risk of heart disease, and it's proportional to the degree to which they lower LDL. There is
but
no
not
possible way for that relationship to not be causal. So claiming, oh, you can't point to a mechanism, that's just nonsense. It's just pure cope. Secondly, I was able to prove that dietary saturated fat does in fact raise ApoB. You did not disagree with that. So just due to increasing the exposure of the vasculature to that risk factor, saturated fat is going to increase risk of atherosclerotic cardiovascular disease. That has been shown in meta-analyses of randomized trials. Most of them do show a link between saturated fat and risk of non-fatal and fatal myocardial
you
infarctions.
don't have
And the
randomized trials.
reason why that these meta-analyses of randomized trials and prospective cohorts don't show as much of a protective effect of reducing saturated fat as some of these other trials would have you expect is because they don't reduce saturated fat to a significant enough degree. Most of these trials do not have cholesterol lowering targets. They just tell people to lower their saturated fat intake. Most of them don't actually record their cholesterol, and when they don't have substantive reductions in cholesterol. And as a result, most of these randomized trials on saturated fat, they only last for maybe 2 years. So
Right.
you're not going to see a massive reduction in overall event rate, but they still do see about a 20% reduction in event rate. So, with
So
all that
I
combined, since we know cholesterol does have a causal relationship with heart disease, we know how much lowering cholesterol will lower your risk. And given that we know saturated fat does raise serum cholesterol, and we know to what degree it would be expected to raise cholesterol, clearly you should lower your saturated fat intake to as much as you possibly can.
Okay, man. I really do have a hard stop at 4:30. All I'll leave it with is I showed data. You just have words explaining why you think that
Right, I
data
didn't
doesn't.
show data. We screen recorded
No,
this, and I showed you. It all happened on
the
screen.
indirect associative data, the weakest form of
No,
evidence that
you
exists.
don't even know what association means. All of this research is correlative. That's how you establish causal relationships. You
Do
are
we do that
trying to
for clinical
find a
trials? Do we do
correlation
that for medication?
between an exposure and an outcome. Randomized
You do a
trials.
randomized controlled trial, which does
Yeah,
not
no,
exist.
no. All data is correlative. That includes randomized trials. You're finding a
You're
correlation
failing
between an
as
exposure and an outcome, so you don't even
failing
understand.
introductory bio.
You don't even understand like what you're talking about. All data is correlative. You're trying to find a link between a correlation and an
All
outcome.
data is
That's
not
true of
correlative.
randomized trials. That's true of prospective cohorts.
All right, man. I got a work meeting. I got to go.
All
Well,
right, take care. Okay, well, that was very stupid. So in short, he has no idea of what he's talking about. He also lied. I sent him a long list, a very long list of meta-analyses of randomized trials on saturated fat, by the way. Um, let me... I'm just gonna... I don't want to show his email. I just want to prove that he lied. He said that I only linked him studies on cholesterol and heart disease and not any on saturated fat. This is the link these are the list of links I sent him on the relationship between saturated fat and ASCVD. These are all meta-analyses. They're meta-analyses of prospective cohorts and randomized trials. And he said I didn't send him a single one on the relationship between saturated fat and heart disease. I only sent him studies on the relationship between cholesterol and heart disease. So he lied. He didn't open a single one of my links, and he probably didn't even read my fucking email. What? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 separate meta-analyses linking saturated fat to increased risk of ASCVD. We didn't have enough time to go through each and every one of those meta-analyses, but point being, the majority of meta-analyses of randomized trials on saturated fat does support the idea that reducing saturated fat intake reduces risk of ASCVD, including fatal and non-fatal myocardial infarction. So he lied. He didn't read anything I fucking sent him. He asked to share research before we did this debate, and he literally did not read a single fucking link I sent him. He also tried to cope and say the relationship between LDL and ApoB is not strong. Again, I showed that evidence. It is very strong. It's clearly causal. He also went back and forth between agreeing and disagreeing with both my debate propositions. And again, the idea that if we can agree the relationship between ApoB and heart disease is causal, and that saturated fat increases ApoB, it would then logically lead to the conclusion that saturated fat increases risk of heart disease due to triggering that causal mechanism. So that was ridiculous. It went exactly how I thought it would. He basically just bullshitted the entire fucking time. 2 people donated for some fucking reason. Dodo donated $3.
Food security experts say the entire population of Gaza will likely fall into famine if Israel doesn't lift its blockade. Integrated Food Security Phase Classification finds nearly 500,000 Palestinians are living in, quote, catastrophic levels of hunger and...
That's great. Funny how they all appear to be normal weight. Thanks for the donation, Dodo.
James, yes, free Palestine from Hamas, that is.
Yes. I can agree with that. Well, thanks for the donation, Dodo. Well, that's it. Yeah, that was just stupid. The guy basically just couldn't accept basic facts and spouted pure nonsense, and then again lied saying, I didn't show any data. I have research, but you don't. Well, anyway, hope you enjoyed that. The stream is going to stay public, so if you want to go back and watch it later or whatever, you can, whether you remember or not. I will be streaming later. I'm just going to do some stuff, and then I will be streaming later. But, take care, everybody.